Yeah, so I mean, I think we all recognize that circulating tumor DNA is a powerful prognostic biomarker in forecasting a patient's likelihood for their cancer, for their colon cancer to return. If positive, and if negative over time, that confers a very favorable outcome that their cancer is unlikely to come back. I think the challenge that still continues to face oncologists is what do you do with a positive result? And what the NRG-GI005 COBRA trial sought out to do was to evaluate for the first time in a prospective randomized trial the utility of circulating tumor DNA as a predicted biomarker for adjuvant chemotherapy in patients with low-risk stage 2A colon cancer. So patients are randomized patients were randomized if they had low-risk stage 2A colon cancer, and based on current practice patterns, their oncologists felt that they did not warrant chemotherapy and were appropriate for surveillance. And in this setting, patients were randomized in a 1-to-1 fashion, either to standard of care observation, where their blood was collected at baseline and at 6 months for kind of retroactive circulating tumor DNA detection and status determination, or they are randomized to prospective assay-directed therapy, where if they had ctDNA that was detected, they were treated with 6 months of adjuvant chemotherapy with FOLFOX or CAPOX. If they were randomized to the assay-directed therapy and did not have detectable circulating tumor DNA, they were deemed low risk and were able to proceed on with surveillance. We use the Guardant Lunar assay. This is a circulating tumor DNA assay which incorporates both somatic mutation calling as well as an epigenomic methylation call for together for determination of ctDNA status. And our primary endpoint for the phase 2 analysis was to evaluate rates of ctDNA clearance between the two cohorts of patients who were ctDNA positive at baseline, those who received adjuvant chemotherapy and those who had gone on per protocol for active surveillance in the control arm. And what we saw was that after 6 months, there was no improvement in ctDNA clearance with use of adjuvant chemotherapy in comparison to active surveillance alone. In fact, in the 16 patients that were analyzed at the phase 2 endpoint analysis, 3 of the 7 patients in the surveillance arm cleared their ctDNA after 6 months, whereas 1 of 9 cleared in the adjuvant chemotherapy. So 43% cleared with surveillance, 11% with adjuvant chemotherapy. Because of these results were not what we had hypothesized when we set out to design the study, the trial did not meet or pass the boundary for futility, and we stopped the trial early based on pre-specified rules as laid out in our protocol. Looking at the big picture, even though we did not see that chemotherapy was associated with increased clearance of circulating tumor DNA relative to surveillance in the baseline postoperative ctDNA positive patients, we still believe that there is a role for evaluation of circulating tumor DNA in future clinical trials. Our accrual still remained very strong throughout study conduct, and to us, this signals that both patients and oncologists have a desire to participate in clinical trials evaluating circulating tumor DNA, so that we can best define how to use this exciting technology and hopefully cure more patients, at high risk for recurrence with colon cancer.